Hi, this is Courtney DiNardo, and I am at MD Anderson Cancer Center in Houston, Texas. And today I've been asked to speak briefly on familial AML. This is something that I think we learned for a long time, that leukemia and other blood cancers were not inherited. And actually, what's interesting and similar to other solid cancers, for instance, is about probably 5 to 10% of patients who have a blood cancer diagnosis, in particular MDS and AML, may actually have an inherited predisposition, increased lifetime risk of developing a blood cancer based on some sort of genetic mutation that they were born with. And this is a particular research interest of mine because I think it impacts patients and us as the medical team. We should be aware of these things because we can optimize our patients with this knowledge. So one is it is important, particularly in patients who are potentially going for a stem cell transplantation. We often use fully matched related donors, family members, as the optimal transplant stem cell source. And if patients' family members share that same underlying predisposition, we would not usually recommend that family member be the stem cell donor source, just given you're giving back the same kind of inherited risk for malignancy. There are different treatment strategies that can be optimized in patients with various different inherited mutations. This is something that more and more research is kind of exploding to try to identify in someone with a germline RUNX1 mutation or someone with a germline DDX41 mutation. What is the optimal treatment strategy for that patient? And for instance, there have been some reports suggesting that lenalidomide or Revlimid may be particularly effective in patients who have an inherited DDX41 mutation, which is just, it's exciting, and I think it's the start of personalized medicine for these patients. There are adults who are diagnosed with a bone marrow failure syndrome. So the things we used to think happened only in children, for the most part, things like short telomere disorders, dyskeratosis congenita, or Fanconi anemia. These patients can have a lot of trouble tolerating standard intensive chemotherapy or conditioning regimens for transplant. So the knowledge of that is really important as you identify kind of what the best treatment strategy should be, and attention to particular toxicity with many high-dose regimens. And then, the last thing is, the more and more you look, the more, or at least the more you're aware of this and the more you test, you're going to find patients with inherited mutations. And then that, allows the family members to decide, do they want to be tested to see if they share this mutation? And if they do, we have now surveillance strategies and follow-up protocols that we're developing, as on a global scale, to try to kind of follow follow family members, healthy family members who have these inherited predispositions, to try to see, can we help in time, future studies prevent malignancies from ever even happening in the first place. So for all these reasons, I think there's a lot to learn and a lot to be aware of already based on the current knowledge for familial AML. So thank you so much for your attention.